If I told you there was a group of medications that has prevented millions of heart attacks, strokes, stents, bypass surgeries, and cardiovascular deaths over the last few decades, would you take them seriously? Because that's exactly what cholesterol medications have done. And yet, few medications generate as much debate as statins. Some people think they're miracle drugs, and others think they are dangerous and overprescribed. And the truth is much less dramatic. Hi, I'm Pharmacist Stan with MediSol Pharmacy in Glendale, Arizona, and I think we need to talk about cholesterol-lowering medications doctors use. We'll start with statins because they remain the foundation of treatment. Then we'll talk about Zetia, bempedoic acid, and finally, one of the heavy hitters called PCSK9 inhibitors. By the end, you'll understand why your doctor picked a specific medication, how much cholesterol each option can lower, and which drugs have the strongest evidence for preventing heart attacks and strokes. But before we talk about these medications and their classes, I think we need to talk about LDL cholesterol. LDL carries cholesterol through your bloodstream, and the problem starts when LDL particles enter the wall of an artery, and over time, cholesterol builds up. Inflammation develops, plaque forms, and that plaque can gradually narrow an artery or suddenly rupture. When plaque ruptures in a coronary artery, you can have a heart attack. When it happens in an artery supplying the brain, you can have a stroke. This isn't really controversial anymore. That's kind of what happens. And researchers have looked at genetics, population studies, and large clinical trials involving millions of patients. The conclusion keeps coming back to the same. Higher LDL generally means higher cardiovascular risk. Lower LDL generally means lower cardiovascular risk. The next question becomes, how do we lower it? Statins remain the first-line treatment for most patients who need cholesterol lowering. And these medications work by blocking an enzyme in the liver called HMG-CoA reductase. The liver responds by increasing LDL receptors on its surface. And think of LDL receptors like tiny catcher mitts. The more catcher mitts the liver has, the more LDL it can pull out of circulation. As LDL levels fall, cardiovascular risk falls as well. Now here's where things get interesting. Statins don't lower cholesterol equally. Some are stronger than others, and doctors often classify them into intensity groups, like low-intensity statins generally lower LDL by less than 30%, moderate-intensity statins lower LDL by roughly 30% to 49%, and high-intensity statins lower LDL by 50% or more. For example, atorvastatin 40 to 80 milligrams and rosuvastatin 20 to 40 milligrams are considered high-intensity statins. Rosuvastatin 10 milligram surpasses a lot of patients because it's actually considered moderate intensity, not high intensity. That shows just how potent rosuvastatin is compared to many other statins. And some statins are also more commonly taken in the evening because your body actually produces much of its cholesterol overnight. But atorvastatin and rosuvastatin stay in your body long enough that they can only be taken one time a day. And this is why two patients sitting next to each other in the waiting room may be taking completely different statin doses. One may need a modest reduction in LDL while another may need an aggressive lowering because of a prior heart attack, diabetes, or significantly elevated cholesterol levels. You'll also hear people talk about lipophilic and hydrophilic statins. Well, lipophilic statins include atorvastatin, simvastatin, lovastatin. Hydrophilic statins include rosuvastatin and pravastatin. And the basic idea is that lipophilic statins enter a wider range of tissues, while hydrophilic statins tend to be more liver selective. So one practical example is rosuvastatin. Because it has a lower penetration into muscle tissue, some cardiologists prefer it for patients who previously experienced muscle symptoms on another statin. That doesn't mean it's guaranteed to prevent side effects. It just simply means that if one statin doesn't work for you, another statin may be and should be worth trying. All right, now that we've covered how statins work, let's talk about the question patients really care about. Do they actually improve outcomes? And this is where statins separate themselves from almost every other cholesterol medication. Statins don't just lower LDL, they consistently reduce heart attacks, strokes, and cardiovascular deaths. And that's what matters. Nobody gets excited because a lab number just dropped. We care because lowering LDL helps people avoid major life-changing events. One of the largest bodies of evidence comes from cholesterol treatment trialist collaboration. Researchers pooled data from many large statin trials involving hundreds of thousands of patients, and what they found was remarkably consistent. The greater the LDL reduction, the greater the reduction in heart attacks, strokes, and other major cardiovascular events. This is why cardiologists care so much about LDL targets. The discussion isn't about getting a better lab report, it's about reducing risks. And that's why statins remain the gold standard. Now let's address the elephant in the room. Muscle symptoms are the most common concern people have with statins, and some patients genuinely experience muscle aches while taking them. That absolutely happens. But there's one of the most fascinating findings in cholesterol research, which is researchers have repeatedly studied patients who reported statin side effects by giving them statins and placebos at different times without even telling them which one they were taking. Well, what happened? Many patients reported very similar symptoms during the placebo periods. Think about that for a second. People experienced muscle symptoms even when they were not taking a statin at all. That doesn't mean symptoms are imaginary, they are real symptoms. What it means is that when people expect a medication to cause a problem, the brain can sometimes play a much bigger role than you think. Researchers call this the nocebo effect. It's essentially the opposite of the placebo effect. The takeaway isn't that statin side effects don't exist. The takeaway is that identifying the true cause can be more complicated than most people think. And the good news is that most patients tolerate statins quite well. And for those who don't, we have additional options. Let's talk about them too. The first is ezetimibe, commonly known as Zetia. So instead of reducing cholesterol production in the liver, Zetia actually blocks cholesterol absorption in the small intestine. Less cholesterol gets absorbed through dietary means, more cholesterol leaves the body. LDL levels drop. On its own, Zetia typically lowers LDL about 15 to 20%. Its real strength is when it's combined with a statin. That's why it's often the next medication added when patients need additional cholesterol lowering, but aren't quite ready for injectable therapies. It's a simple once-a-day tablet and is generally well tolerated. For many patients, it's the logical next step. The next medication is called bempedoic acid, aka Nexletol. This medication is newer than statins and Zetia, and like statin, it affects cholesterol production in the liver, but it works at a different step in a pathway than statins. One reason it gained attention is that it became active primarily in the liver. Because of that, it may be a useful option for some patients who have difficulty tolerating statins. The CLEAR Outcomes trial helped put this medication on the map. Researchers studied statin-intolerant patients and found fewer heart attacks and strokes along with meaningful cholesterol lowering. By itself, bempedoic acid typically lowers LDL by about 15 to 25%, and the effect can be even greater when it's paired with Zetia. It's another example of how cholesterol treatment has expanded over the years. Doctors have now multiple tools available when statins alone aren't enough. Now let's talk about the most powerful cholesterol medications currently available, called PCSK9 inhibitors. These medications change the cholesterol landscape. And to understand why, imagine your liver is consistently trying to remove LDL particles from circulation using LDL receptors. PCSK9 is a protein that helps break down those receptors. So fewer receptors means less LDL is removed. Well, PCSK9 inhibitors block that process. The result is simple. More LDL receptors survive, the liver removes more LDL, and then the LDL levels just plummet. We're talking reduction of roughly 50 to 60% and sometimes even more depending on the situation. The two major medications are repatha and praluent. And clinical trials showed dramatic cholesterol reductions and fewer heart attacks and strokes. For patients with very high cholesterol risk, a genetic condition that causes dangerously high cholesterol levels from birth, or LDL levels that just won't budge under statins and Zetia, these PCSK9 are incredibly effective. Historically, the cost was the biggest barrier, but fortunately, insurance coverage has improved quite a bit over the past years. But cholesterol treatment continues to evolve because there is value in this. Researchers aren't just developing stronger medications, they're also trying to make treatments more convenient for patients. There's a newer medication called inclisiran, brand name Leqvio, that uses a different technology to reduce PCSK9 production inside the body. The practical takeaway for patients is simple. After the initial dose, it can be administered only twice a year. This is very different schedule from what most people are used to, and it's one of the newest approaches in cholesterol management and an area many cardiologists are watching closely. So when you look at cholesterol treatment today, there isn't just one medication, it's an entire toolkit. And statins remain the foundation because they have the strongest evidence for reducing heart attacks, strokes, and cardiovascular deaths. Zetia offers great additional LDL lowering and pairs very well with statins. Then you have bempedoic acid, which provides another oral option, especially for patients who can't tolerate statins. PCSK9 inhibitors also deliver some of the most powerful and dramatic LDL reductions we've ever seen. And new therapies continue to expand what's possible. And at the end of the day, cholesterol treatment isn't about chasing numbers or on a lab report. It's about reducing risks and helping people stay out of the hospitals, avoiding heart attacks, avoiding strokes, and living longer lives. If you found this breakdown helpful, like, subscribe, and share this channel. I'm Stan, your pharmacist on social, because understanding your meds shouldn't require a pharmacist degree. If you are in Glendale or Phoenix area, come check us out. MediSol Pharmacy is here for you. Walk-ins welcome. Stay healthy, and I'll see you next time.